Thank you, Andrew. And I will state right off the bat that everything he said I agree with. All of the comments, future directions, certainly we are very much aligned with the idea that we have data, but we don't have all of the data. And as when I was talking to various attendees here, I was thinking about some common themes, that this is a different class than we really thought about when it came to therapeutics and risk. While there are similarities, there certainly are things that are quite different. And we're going to go through a little bit of that because that's the challenge that we all face today and we're going to face over the next decade, is figuring out what is the right framework for addressing what is clearly a class of substances that has therapeutic benefit, has risk, and has cultural connections and spiritual meaning to various communities throughout the country. So we don't have a guidebook yet on how to do that, but actually those who are here are probably going to be our greatest partners when it comes to that. So a little bit of housekeeping, no disclosures to report. As Andrew mentioned, I do have a Saturday clinic, and I can say that I have seen a signal there too, where lots of patients are now asking about psychedelics. In particular, ketamine, that's probably been the one that's most asked. And I see that signal, even with that small sample size, that they're reading about it. They're getting not only information from various sources, but this is the other shift that we talked about over lunch, that our population that we serve, the patients that we serve, are more educated. They have information at their fingertips. We have to get them the right information. That is going to be part of our messaging challenge. But today we're going to talk about a couple things that I think you've seen various NISDA slides already. NISDA's far from perfect, but it does give us an insight into some trends and, more importantly, areas of where we will need to focus our resources. And that's the other part to this, is that we have to consider various perspectives. We're going to also need to be inclusive, demonstrate that not only we're going to balance risk with the therapeutics, but we're going to take into consideration the various equities that various populations share, and understand that we have not had a perfect record when it comes to policy, but we do have sincere intentions, and I believe everyone in this room is a partner with regard to not only that goal, but the understanding that those sincere intentions are going to move us to the right place. I think everyone knows who SAMHSA is, so I won't spend a lot of time on this slide, but we're the behavioral health grant-making arm of HHS. While there's certainly grants with regard to other operational divisions, our focus is mental health and substance use. We're a relatively new agency, but we have, in addition to grants, which is probably 90% of our function, we certainly have educational offerings, technical assistance, a number of other things. In particular, you'll see the Office of Tribal Affairs Policy. We interface a lot with our tribal communities, and that's why I think that equity is going to be important as we move forward as well. So really quick, just as our strategic plan, this is all the way through the next couple years. It's important to recognize that psychedelics fit into this space. They fit certainly in the space of preventing substance use and overdose, although we think that the overdose risk for psychedelics is fairly low when it comes to single substance use. And then, of course, the idea that we can promote integration, that not only screening and brief interventions and referrals to treatment are important, but also the idea of recognition that there are therapeutic options. I will say that when I talk to my colleagues in primary care and also other specialties, there still is a messaging issue when it comes to psychedelics, and that's one of the parts of educating our workforce. that I think we're going to have to move forward with regard to the right messaging. Getting the right folks in the room to help us with that is going to be important. But I meet with docs of other specialties all the time, and when I say psychedelics, I see the eyes gloss over, and they think about things like LSD and these anecdotal adverse events that have occurred and and have been publicized. But in reality, it's so much more. And SAMHSA is committed through our strategic plan with regard to a trauma-informed approach, and I think there is some shared equity with psychedelic therapeutics in that space. As we move forward with our federal partners, we'll certainly be working towards that as well. This is just to, I guess, for people to look at as I talk about that this is complicated. Psychedelic use, hallucinogens, predate Homo sapiens. Use is probably prehistoric man was ingesting psychedelics and in the form of mushrooms way back 50,000, 70,000 years ago. So when we couple that with the idea that there is obvious therapeutic benefit in terms of depression and other mental health conditions, it's important to recognize that we also have to balance the risk. We have a messaging issue. Certainly there is going to be more that we're going to call upon all of you to do when it comes to vetting some of the things that we'll be trying to do over the next several years. In particular, when it comes to messaging, the most important thing to recognize is that when there's a bad event, those things get amplified. When there's an adverse event, something that happens to a celebrity, those things get amplified. Opioids have gotten a lot of attention recently, and when we think about what's happened with psychedelics, in particular, as Andrew mentioned, Matthew Perry, that brought a lot of attention to SAMHSA. I'll say we saw, almost a tenfold increase in questions in traffic about psychedelics after his death, and really we were essentially unprepared as a federal government with regard to our messaging, and that's something that we're looking to remedy. So this is just a glimpse of over the years. So hallucinogen use has really increased. When we think about comparing 2021, 2022, 2023, we can see we're all the way up past 8 million at this point, over almost closer to 9 million at this point. And when we think about how that has progressed, this is not necessarily, when we look at that compared to, let's say, opioids, it's almost on the same order of magnitude, very close to that, but these are inherently different. When somebody thinks about opioid use, they think of overdose, they think of risk of death. That is not necessarily something that we're going to look at in the same vein when it comes to hallucinogens. And that's where our messaging is probably our strongest, is that while they carry risks, the risk of overdose death is not the same. And I think that's something where we can really lean into the data, because the data really does support that too. But we can see that this is growing over the last several years, and we expect that to continue, not only for therapeutic use, but also, as many have mentioned, there is a lot of use that is going on with regard to online delivery, as well as what may be available in the communities. And I just would want to compare that while this is at 8.5 or 8.7 million, as it goes up, our messaging to youth is going to be important as well, because they probably do represent the place where there is the greatest risk. And we can tailor messaging, just like we did for other things. Our adolescent population is very smart, very savvy. If we give them the right information about prevention, about risks, they make good choices. And that's what we've seen with tobacco, we've seen that with infectious disease mitigation, we've seen that the public in general responds to good information if they get it and it's digested in the way that we have good partnerships with local communities. So this is another slide at NISDA. I will just preface that the map is only for hallucinogens, not for the other substances. But you can see the age group with with the greatest rate for past year hallucinogen use is really at that 18 to 25. Now we hope that during that time they're adults that have made decisions throughout their lives. They are capable of making an informed decision about their use of hallucinogens. But I think we still have to do a lot when it comes to getting them to understand that risks for this may be different than other substances, but not all the risks are benign. And having them make informed choices. We can see that as far as the distribution across the United States, what we really talk about is the West at the highest rate. And there may be some reasons for that we don't fully understand, but I will say that there's varying state policies that certainly make availability and use a bit different when we compare various jurisdictions, and I think that probably plays one role. And the other part may be not just availability, but competition among other available substances. I think that's an area of future discussion and future research that certainly the federal government's very much interested in figuring out. As we talked about earlier, and this is something that I will thank our NIDA colleagues for as well, is this idea that while it's been increasing over the last several years, and we see this bump, we also see the bump in older adults. And I don't want to say I'm an older adult, but I fall in that other age group too. And I've seen this clinically. We've seen this also marketed this way. I will not disclose anything in terms of protected health information, but there I have a patient who was 60 and has a former veteran, but he was able to talk to me about some of the ambivalence he had about using hallucinogen. And my sample size was relatively small, but what I can see is that not only is this now being discussed in my office, but they told me that they're actively getting marketing information. They're getting marketing information from when they do a search for depression treatments, that this now comes up in the algorithm. And that's something that I can say we did not expect. I didn't expect that to be so aggressive. I would prefer to have an educated patient, so we discuss the pros and cons, and certainly there are instances where this may be appropriate. But the most important part is that as we try to educate patients, we have not done a great job in educating providers. I was recalling in medical school, I learned about hallucinogens as a class, and all we heard about was, well, yeah, they may increase serotonin, but all I heard were the negative effects. We never really discussed the therapeutics. And now I see this shift, and that's probably the other place where I think we have some leverage. Just as there are now medications that are approved, there will be test questions that can come out of that. And I will often say that if we test for it, then the students will learn it. If we test for it, then licensing boards will ask about it. And if we test for it, then we'd reduce the stigma that's attached to it. So I'm off the soapbox for a moment just to talk about, we see varying percentages of use. Now, all of this is available on our website, so I don't need to go through all of this, but you can see really psilocybin, LSD are really at the highest levels when we think about the two highest. And I will say that when we think about all of the psychedelics as a class, I believe these are probably underestimates. We really do think that psychedelic use, hallucinogens, I've used them interchangeably, and I think that was the first point that I forgot to mention. A lot of times we don't even speak the same language. Are we talking about a medication? Are we talking about a plant? Are we talking about an organic product? Are we talking about something that is a spiritual or enlightenment tool. A lot of times we don't even talk about this in a consistent way. So I think that's going to be our first part, is understanding that we are not speaking the same language. What tribal communities are talking about and what the medical community talks about are two different things. And certainly what law enforcement and other regulatory agencies might talk about might be even a third space. So when we talk about past year initiation, we can see 1.5 million people started with hallucinogens last year. When we think about that compared to pain reliever misuse, stimulant misuse, it's far above those. And that should speak volumes to access. And I often think about it this way, that when we talk about adolescents don't have a lot of money. I can say a lot of them don't have a lot of money. But so this means that this access is relatively inexpensive. And that's something else that when we try to reach out to our harm reduction arm of SAMHSA and our prevention folks, we really want to make sure that they understand that access for this is growing, not just in those western states, but all across the country. Past month, we're thinking about 2.6 million people. Again, when we think about pain reliever, cocaine, methamphetamines, considerably more. But there's something that we have to nuance with this message, that we don't understand always the intention of that use. Is it used for recreation? Is it used for some therapeutic benefit? Is there some other aspect that we just haven't delineated? And I know we've talked about the limitations of NISDA, so I'll hop off of that. But the idea is that the risk is different because the intention is different. We're generally pretty clear when individuals are using cocaine or methamphetamines what the intention is. We're a lot less clear when it comes to stimulants, psychedelics or hallucinogens. And now when we think about co-occurrence, this is where I think we really need to lean into the harm reduction and understand that there will be populations where this is not appropriate. Educating folks to understand that risks, in particular for co-occurrence, is going to be something that not only will we research more, but our messaging has to be targeted for this. As you can see, I often say the numbers speak for themselves, but when we think about co-occurrence, we're really talking about marijuana being at the highest level, but nicotine not far behind. When we think about the mortality risks that come with nicotine and alcohol, I think, those are always the elephants in the room that, we don't devote as much attention to them. Opioids get a lot of attention, but in reality, it's those substances that tend to create the greatest mortality impact. So when we think about hallucinogens and major depressive episodes or mental illness, we can see that there is a high degree of co-occurrence. And when we think about messaging in particular for those individuals, we have to understand whether or not they're taking it with the intention of relieving some psychiatric symptom, or there's some other intention. And so I think that's where our data is lacking, and we hope to gain more insight as we continue to study this through great partnerships like all of you here. The regulatory environment is certainly varied according to jurisdictions. Certainly there are places where hallucinogens are decriminalized. There's other places where we've actually gotten some federal approval for some of these medication options. And we can see some states are further along than others in understanding the therapeutic impacts, and then other states probably there's more underground use. So because of this, we find it very difficult to come up with a federal policy that's going to be a one-size-fits-all, and that's really the bottom line here, is that we have to be a little more disruptive. While we have our lanes, FDA has their lane, NIDA has their lane, SAMHSA has our lane, we're going to talk to each other And that's sort of where I think our future direction is that talking to each other is going to be where we'll be able to actually come up with a better approach. And certainly we have engagements from all of our operational divisions. Speed of government, though. I don't want anyone to think we're going to come out with a paper tomorrow, but we are working on it. When it comes to equities within the Native American community, certainly we have to recognize that there is a different perspective there that we have to respect. And certainly that's going to be part of our overarching policy and certainly considerations there. I know we're getting close to the end. We all know there's lots of new applications for hallucinogens and psychedelics and various indications that are being pursued. You can see over the years that it's almost the hockey stick going up in terms of the interest from a therapeutic standpoint. You already know about the various medications that have been approved for breakthrough therapy. Psilocybin in particular, I've seen clinically to be quite helpful. Certainly the FDA has more than agreed with the idea that it is very effective for depression, or at least for breakthrough therapy. And there's certainly other things that are moving closer to phase 3 as well. We had the FDA represented very well earlier today, so I won't go more into this. We do know that there are issues with some of the previous studies and applications, so I won't comment on that other than we have to balance the risks. For patients, we have to understand that we're not going to make everyone happy, at least the first go around, but we're going to do our best to make sure that we balance the therapeutic benefits for the population with the risks from a public health standpoint. And this is sort of where I'd like to leave it, is that, you know, we're doing a lot more. We have a lot of folks who participated in our town hall a couple weeks ago. That's just the beginning of our conversation. We understood that we didn't have all the answers, but we did understand that you could certainly help us along the way. We're going to collect a lot more data. We're going to try our investment in terms of not only through partnerships with those of you in this room, but from a policy standpoint, we're looking for further federal investment into this space. Understanding that our Center for Mental Health Services is also very much invested in the therapeutic implementation, and understanding that they're going to lead the way in terms of potential funding for our various mental health grants to utilize what is approved or evidence-based. And we leave the evidence-based decision to the actual grantee, which is important, that we don't dictate from Rockville what a community may need. And our Center for Substance Abuse Prevention certainly is our equal partner in this as well, where we really do have to understand that the messaging for this has to be quite unique, and because the risks are quite different. And we're going to continue to give resources towards our provider education resources as well, our technical assistance centers, in addition to our evidence-based resource center. We hope to have some products come out of that as well. I know there might probably be a lot of questions, so I'm going to stop there.